Hi, we are live and about to start a great conversation with 5 Point Physical Therapy. And she is just, hi, Stacey.
Hi,
How are you?
I'm good.
Good. I'm so excited to be talking about all this stuff. So while I was waiting for you to come on, I just mentioned your name and the name of your company, 5 Point Physical Therapy. And I thought while we're waiting for people to join us, or for the people who have been waiting for us, maybe do a little introduction of yourself, what your background is, what your company does, and stuff like that. And then we'll dive into all things pelvic.
Sure. I wish I could get all the little stuff written on here down, but I'm just going to ignore it. I barely see my face, but it's fine.
Okay.
Okay, so yes, I am Stacey Futterman Tauriello, and I own 5 Point Physical Therapy, established in 2011 in New York City. I became a physical therapist almost 30 years ago I wanted to work in a hospital, but that didn't stay very long. And I became an orthopedic physical therapist and had this little funny specialty that was given to me as a new grad in a hospital. It said someone wanted to get a PT trained in what was called biofeedback at the time.
Huh,
And yeah, and now I am years later with a practice in New York City and a practice in New Jersey. And here I am as a co founder of Not Your Mother's Menopause. And I always say this, if you would have caught me about 7 or 8 years ago, I was very passionate about prenatal postpartum. And now I'm like super passionate about perimenopause and menopause because I'm deep in it,
yeah.
man. Deep in it. And it's interesting because as like you and I are both deep in it, also like the universe is deep in it. Like this is the biggest talk, right? Like as compared to this wasn't really a talk even in the pelvic health world 10 years ago.
Oh,
It was
really?
no.
Can you
No.
talk a little bit? Can you, before we get into pelvic, before we get into like all of that, I just wanted to just talk about what pelvic health is, or like talk about maybe breaking it down. Like, what is the pelvic floor? Because I think that is also something that is talked about so much more than it ever was. I mean, I'm thinking when you said that you've been doing this specialty for 30 years, I'm thinking like 30 years ago, did people get pelvic PT? But I guess they did. But now I feel like it's
Yes.
really, yeah.
And the physical therapy, so it used to be very, very, very long time ago, even like before PTs, the nurses would do it back in the day. Like we're talking years and years and years ago. I mean, Kegel, Dr. Arnold Kegel, I think his first name was Arnold. That was like 1936. He developed this kind of understanding of this pelvic floor and the Kegel exercises that was named after
Wow.
him. Yeah, it's pretty crazy. It's pretty crazy. And again, my mentors that taught me were doing it for 20 years when they were teaching me. So this is not new to any aspect of women's health. And where I learned 30 years ago was a women's hospital in Baton Rouge, Louisiana. That's where I went.
That's crazy.
They only saw women. And I'll never forget it because they gave us a tour. Excuse me. Um, um, so
You're
hold
getting,
on.
are you getting a little verklempt when you're talking about your time in Baton
I
Rouge?
am. I am. I'm getting so verklempt. I'm sitting upstairs and I think it's the heat that we're getting like actually warmer weather. Anyway, so I remember touring there. You know, every woman that gave birth had a physical therapist that went to their room and talked to them about pelvic healing. If they had tears in their pelvic floor after childbirth, they would go down to the physical therapy department and they would get like whirlpool tubs that they would go in to soften the tissue. They would teach them body mechanics, blah, blah, blah. Like amazing.
Yeah.
I feel like we're going in reverse,
Yeah.
but that's okay. So, but that's what used to happen. And
Yeah.
that was like this amazing thing. Um, but menopause wasn't like a big topic, even though we used to see all these patients that had urinary incontinence and things like that. It wasn't I like, and again, maybe I'm blocking it out, but it just we discussed it, but it wasn't a huge aspect of it. And hormone was never talked about as part of the issue, which we can talk about later. But
Yeah.
the pelvic floor is a bunch of muscles that support your organs. I mean, it's your undercarriage. It's the thing that holds everything up. It unloads the spine. It closes orifices. It really is a supporter. It's basically all these muscles underneath. Now, they can't save the world. Like your body functions as a lot of other different things, but it's just the bottom support that you can't really see and no one really talked about. I mean, that's really the reality of it. Even when you go for back pain and you're a woman, they never ask the questions that they need to really ask, both
Right.
from a physician standpoint and from even a physical therapist standpoint. You know, like if you're an orthopedic physical therapist and you're maybe a male and you're treating a woman that just gave birth or maybe is in perimenopause and menopause with back pain or hip pain, you're not asking the important questions that might also go with some of these
So what
pains.
are some of those things that can come up when you, let's be, I guess, because we can specifically focus on some of the things that can happen in the pelvic floor during the perimenopause and menopause transition.
Sure. So big questions on a sheet of answers that should be hung in every women's bathroom. Do you leak urine? Okay. Do you leak urine? Whether it's cough, sneeze, laugh, jump, run, jump on a trampoline, anything like that. Um, do you have a history of constipation?
Mm. Hmm.
Um, do you have pain with intercourse or pain with an OBGYN exam? Okay. Those are not normal. Can you sit through the movie Titanic? 3 hours and a lot of running water. You should be able to. And I don't care if you drink this much water at a time because you have to drink 37 ounces of water in 20 minutes to get a full bladder. That's what they do when they give you an ultrasound,
Yeah.
right? Like they
Yeah.
tell you, hey, drink 37 ounces of water 15 minutes before you come in. You're going to have a full bladder at the end.
Okay.
So if you want to feel what a full bladder is, but I drink a lot of water is not a recipe to go to the bathroom every hour.
Okay.
Not normal.
Yeah.
What do we say? Constipation,
Pain with
urinary
intercourse.
frequency, urgency, leakage, pain with intercourse, big telltale
And these
signs
are
that there's
things that
something
are,
not right.
and these are things that happen. These are the things that you see in menopausal women or perimenopausal
Yep.
women more. Yeah.
Yep.
And what causes that? I mean,
Well, I think the changes in hormone are now, there was a big episode with Rachel Rubin. I don't know if you saw that video that just came out.
mm-mm,
It's live all
haven't,
over the place.
I
It's
haven't seen it yet.
really good.
Yeah.
And it's about the biggest thing that they're talking about right now is vaginal estrogen, but the changes in estrogen, right? So if we look at the changes in estrogen just in our overall skin, our face, our boobs, our body, what happens, right? Are we robust? Are we like plumpy and beautiful? No. Like
Sad.
we sag. We sag. We get weak, right? Like, now everybody's like, eat your protein and, get your strength training in because you're losing what?
Muscle.
Muscle,
Right.
right? Well, guess what? In your pelvic floor, to hold back some of these closures that happen, it relies on plumpy tissue and muscle.
Yeah.
And and so even though someone might have had, let's say, two children or no
Yeah.
children at all of a sudden they hit an age and they go, I'm leaking urine. right? And they may start to join an exercise program or do things, and then they realize, oh, I can't jump or I can't do certain things. And then they say, well, I've always had back pain or I always had hip pain. And then it just like all the puzzle pieces kind of come together. So that's usually the cause of it for sure. I mean, listen, if you've had children and you've passed them through your vaginal canal and you're lucky enough to get through it without urinary incontinence, you are ahead of the game, right? You are. Some people get through it and then all of a sudden, for years, they don't have it and then they have it.
Hmm.
So a lot of the times it will start with that urinary frequency and urgency, which is not incontinence, but then it'll turn into it.
Okay. And what how do people know, like if they have back pain or hip pain, like what's the best way for somebody to determine if it's indeed a something going on with their back or if it's a pelvic issue?
So those questions I just asked, if you have back pain or hip pain and you've answered yes to one or more of those questions, most likely you have some form of pelvic floor dysfunction.
Okay.
If your bowel movements are good, you have no urinary frequency, urgency, leakage, you have no pain with intercourse, you or no like pelvic pain in that area, it, it's a long shot that or like another symptom is like urinary retention too, like feeling like you go and you can't completely empty, things like that. Anything having to do with those aspects of it,
Okay.
it's a long shot that it's, it could also just be your back or your hip, right?
Right.
But if you have that and you've answered yes to one of those questions,
Interesting.
most likely it's a part of the puzzle.
Yeah. Interesting. That's very interesting. So so I go, let's say I'm patient A, I'm having 2 out of those 10 symptoms or 3 out of those 10 symptoms, and a friend says, have you ever thought about pelvic PT? It helped me a lot. So I come into your office, and what is that like? What does a visit to a pelvic PT look like?
So we basically take a really good history because we want to find out exactly what is going on and when it's been going on. And again, I always look at it as like your story is a part of how what I think is truly going on. Like even before I examine you, I always have like a synopsis of what I'm probably going to see when I take a look at you. Most of the time, pelvic floor muscles are not as much weak as they are imbalanced. So they might be more active or tight, where they're overcompensating for stuff. And that's then pulling on the back. And that's also
Right.
creating the urgency, frequency, constipation, pelvic pain, things like that. A lot of the times they're overactive, which is why Kegels don't save the world. Pelvic floor contractions or squeezes don't save the world. And if you're too tight or imbalanced, and then you go to an exercise class, whether it be Pilates or whether it be, any sort of like class, and the pain gets worse or the frequency gets worse. Now you're overtraining these muscles in a way that they shouldn't. So a lot of the times we see this with also patients that have had like 2 or 3 C-sections. And they're like, but I didn't pass a baby through the vaginal canal. Why should I be having these symptoms? Because your weak abdominal muscles and your pelvic floor thinks it has to work overtime. And it's working and working. So when it's doing everything, it's doing double time. And that creates, it's all about
So
balance,
the
right?
pelvic floor will take if you have like weak lower abs, your pelvic floor is going to take over and get clenchy.
Yeah.
Interesting.
Could.
It
I
could,
always say
right.
could,
Yeah,
right?
right,
And we
right.
see this with all aspects of the body. The
Yep.
knee, right? You've got weakness in one side and tightness on another, and now all of a sudden you got knee pain, right? So
Yeah,
what does the physical therapist do? Trying to stretch out one side and strengthen the other side and get you what?
right.
Balanced. It's the same thing in the pelvic floor. With the exception that I believe that women just think this is a natural part of aging.
Mm. Well,
And
that's a very interesting point.
why should I work on this?
It's
Why should
part
I work on
it's
this?
like part of the whole notion that we have to suffer as we as we
Right.
age, that there's going to be pain. And I think that women are so used to accepting discomfort and suffering on not only physical levels, but emotional levels as well. Um,
Well,
yeah,
they're also, I don't want to use the word gaslight because I know that's like a big word that's being used right now. But, they've done studies like a long time ago about OBGYNs or primary care physicians that go in and they say, "How you doing? Everything good? You good? You good? Right? Good. Yep. Everything good? No issues?" And what does the woman say? "Yeah, I'm good.
everything's
I'm
fine.
good."
Everything's fine.
So they took a combination of that and then ones where they ask the question, any frequency, hesitancy, leakage of urine. We cough, sneeze, laugh, as specific as the physician could get. And then they ask any pain with intercourse or pain with penetration or vaginal pain or vaginal dryness or things like that. And so the difference between the two answers were so drastic, right? When they just took the extra 2 or 3 minutes
Interesting.
to go through that
Mm,
history. Right.
that's very
Right.
interesting.
So we get as physical therapists, as pelvic health specialists, we try to get as specific as possible when asking these questions so we can really get down to the nitty gritty of what's causing what.
So what kinds of things, like if you didn't go, like what kind, what I'm trying to say is, like, a lot of times women will go to their doctors and they'll say they're having these issues, and the doctors will send them somewhere, and they'll wind up going down like a surgical route or something like that. How do you address so if I was having these issues, like, what, just for people who have never had a pelvic PT exam, it's an internal exam, right? So is it like going to the gynecologist, or is
No.
it like, yeah,
So no stirrups. We do use gloves with lubricated finger. We're testing muscles. We're looking at tissue, things like that. We're looking at how it contracts, relax, bear down. Painful, healthy tissues shouldn't hurt,
right,
right? So if you have a tight IT
yeah,
band and I touched it, it's
yeah,
going to hurt, right?
you're
You're gonna
gonna
be
hit,
like,
yeah,
ah,
yeah,
right?
yeah,
But if it's not going to hurt. So, again, we're kind of looking at that aspect of it. The thing with the physicians, like right now, especially in this perimenopause, I had a patient who is in her 70s, obviously through menopause with urinary incontinence. And I asked her, I was like, okay, she actually was Medicare. And with Medicare, you have to have a physician referral. So I said, are you like, she's like, I've gone to my gynecologist for years and years and years. And she had pretty bad incontinence. We're talking 2 or 3 pads a day. And I said, because, one of the things we have to get a script for PT for people with Medicare, other insurances we don't, especially in the state of New Jersey. But she asked her doctor, her gynecologist, and her gynecologist, I don't feel comfortable giving you either of those, which was vaginal estrogen. And she sent her, the only way you can do it is you need to see a urogynecologist, which is a gynecologist and a urologist combined. Well, how long do you think it takes to get in to see
yeah,
the specialist? So
forever,
August.
yeah,
What was interesting is she's like, I have a really good primary. And so I helped her write the portal message like, hey, I did a consult with a physical therapist. Here's what I need. No problem.
amazing,
Sent the script in. So why?
yeah,
Why is a gynecologist so afraid of, forget about the vaginal estrogen, because we can talk about that in a second, but sending patients that have urinary incontinence to a physical therapist? Like, it's benign.
I know.
It's benign. Really sad.
Stace, there's just a question.
Sure.
Um, Sue, with her whole, she has a long name, but I'm just going to call her
Oh,
Sue
I
because
can
that's the
see
beginning of it.
these
Oh,
now.
can you see it? So you
I
see what part of, I pinned that so you can see it. So what part of New Jersey are you located in?
We are in Melbourne.
Great.
We are in Melbourne, Sue.
Yeah.
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 Oh, if you
Definitely.
pin them, I can see them.
Yeah.
Sorry.
Okay. Now we know. All right. right. I'm going to unpin that one. Okay. So what kinds of, so one of the things you mentioned before was vaginal estrogen, and that is something that comes up not only when we're talking about pelvic health and menopause, it comes up obviously a lot in menopause. So how does that help you? Is that
Yeah.
something you work with? Is that something you recommend
Yes.
for people
Yes.
with? And it's interesting,
Yes.
you know, what I'm finding the most interesting about this is that how everything, when we're talking about our age group, midlife women and pelvic health, we're really talking about urine. I mean, obviously we're talking about painful sex and all that kind of stuff, but it kind of all comes down to like, are you peeing in your pants? And we've come to accept on so many levels, and I see this all the time in my work. It's like, as a personal trainer, we see this where people accept it as normal. And what I always like to say to people that I work with is it's not, it's common, but it's not normal.
Yes, and it's common. Okay.
Right? It's not like you're not a weirdo if this is happening. This is like,
Yes.
and it's not
Yes.
anything to be embarrassed about because this is so incredibly common. And being treated for pelvic PT, as someone who has been treated for pelvic dysfunction, pelvic PT, it's an amazing feeling to be able to feel relief without really aggressive intervention. You know, it's amazing.
Yeah, it is. It is. And this needs to start to be the standard of care. And it needs to start to be discussed with your primary care doctor and your gynecologist, where you're having these healthy conversations about, hey, my vaginal tissue feels dry, right? Like, or, I'm starting to get this weird urinary frequency type situation. Vaginal estrogen isn't like the end all be all. Like, again, you have to put the puzzle pieces together, but it really can be very supportive and very helpful. And it's now they're coming up with studies that it really does prevent in this like older woman that's probably going to start to get urinary tract infections,
Right,
prevent the urinary tract infections, because if you make the tissue healthy, the bacteria, the vaginal tissue is supposed to have it's supposed to be healthy. I mean, that's really the goal. It's
right,
supposed to be healthy,
right,
right? So if your skin is really dry, right, do you not put anything on it?
right,
Like, do you not like
right,
treat it? Like, do you not like, and they have done studies that vaginal estrogen, even in women with estrogen positive breast
right.
cancer, is now safe for them to use because that estrogen does not go through the bloodstream. So there's a lot, again, that's like, and obviously you want to talk to your, oncologist and things like that, but it's so benign.
Yeah,
I mean, it's something that, it's like the one thing right now that, again, what I didn't learn a lot. Um, Back in the day, like we didn't have like in my pelvic health courses, we didn't have a course back in the day just on menopause. We kind of
right,
kind of brushed over it, right?
right.
Oh, I see a
Yep,
question from Julie.
yep,
Can starting HRT help with pelvic floor issues? So, yes, it can. And I think as part of that HRT, um, that vaginal estrogen needs to be a part because it's like you're watering the whole house to get the plant, or do you want to water the soil in the plant,
nice.
right?
Yeah,
Like that's
yeah,
like the analogy that you want to do.
yeah. Very good. Are there other ways to treat are there other tools that you use in your practice to treat pelvic floor dysfunctions other than, you know, manual work or things like that? Like what if it's really bad? Like what if I don't know, what's like the worst thing that can happen? I
Well, you could
automatically, of
have,
course, go to like,
okay, so I'll give you an example. Like the worst thing that you can have
I
really
guess prolapse,
is
right?
prolapse,
Yeah.
right?
Okay.
So I just took a course on pessary fitting, which is very interesting. I work for the Herman and Wallace Institute, and we were out in Seattle, and the educators are we decided we were going to get trained in doing this. And a lot of the times this is a urogynecology thing. This is a nursing thing that they like would fit, but PTs are getting involved in it. And it was hysterical because these are teachers I've been, teaching with for years and years and years. And I became the demo and they were like, they're like, oh, yeah, I was fit last year for this, right? So, prolapse is when organs have fallen down into the pelvic cavity, whether it be the uterus or the bladder or the urethra. And what happens is it makes incontinence a lot worse. It can make incontinence a lot worse. And a lot of the times when it is grade 2, grade 3, meaning it's really kind of fallen down, you need something to support it. And these pessaries help support it. The muscles will help. So what we can do as therapists, and you know this, Allison, as trainers, is we need to handle our pressure management,
Mm-hmm.
right? As to not bearing down and utilizing good core
Mm-hmm.
contractions that bring everything together to support, to lift.
Yeah.
And that can help a lot as well. Some of my runners have to have a pessary in
When they're
to
running.
run.
Yeah.
Yeah. Yeah.
And that just
Because the
provides.
urethra, yeah, it just provides that stability. And what patients will find is throughout their cycle,
Mhm.
even in perimenopause and menopause, you still kind of go through a hormonal flux or cycle, and they'll find that they leak more during certain times, and the running is really hard on their body.
Interesting.
Yeah,
Very interesting.
yeah,
That's great.
yeah,
Cool.
yeah,
Is there
yeah.
anything else that like we should touch on before we say goodbye? Any um
Um, I think it's really having that conversation with your doctor, and that if the doctor isn't supportive of your decision to ask for whether it be like questions regarding what's going on or what you can do to help or getting hormone replacement or vaginal estrogen or anything like that, find a new one. I'm really into this thing because I'm like it's so important, and having a supportive physician that will also support you in finding a pelvic health specialist is really important. And again, even if it's just an eval and treat and saying, "Hey, you're working with this personal trainer. Here's what I want you to do
yeah,
instead."
yeah,
The bladder is a quick learner.
yeah.
It responds really quickly. Colon not so much. Doesn't like to travel, doesn't like change. But there's a lot of alternative medicine that can be done to be able to support it. And we
Yeah,
have a lot of new tools, and knowledge is power. Just after a couple of visits of like coming to see us, it's like patients are like, this is a game changer,
yeah.
like how come I was never told this?
Right. I know, like not I think people are fascinated when they learn about the pelvic floor and learn about what it does and learn about how all the organs kind of sit in that little pelvic bucket and they have a little hammock underneath and that hammock has to be able to maintain um like the pressure, like
Yeah.
you were saying, the pressure and
Well, I'll give you
yeah.
this, what's really even crazier, because Julie
It's a,
just asked,
there's two really good questions in.
is there ever too late, right, to start pelvic PT? Well, I'll give you this. Okay. In nursing home settings, okay, nursing home settings, when they put patients on that are in diapers, right? When they put patients on bladder retraining programs, getting them to get to the bathroom at a certain time and putting them on scheduling and that type stuff, they've reduced incontinence
Mm.
substantially. And that's just from an education standpoint of understanding when patients need to urinate, getting them, whether they have dementia or not, like retraining, which is a lot of what we do with like urgency frequency
Yeah,
happen. And this is with just the
yeah.
elderly, right? So,
There's another question here about, there's actually a question that kind of, do you see
yep.
that one? How long does therapy? Yeah, that's a really good one. Like, how long does it
So,
take? How long can somebody expect to make change? And what you were just saying with like the first part of it is really education and sort of that mind body connection, right? And then the second part is the physical, working on the physical
right.
aspects of it.
So peeing at night, or what we call nocturia, the body produces less urine at night. That's what it's supposed to do. So getting up at night is usually a follow. And again, getting up one time a night, unfortunately, in menopause can be normal. Now, whether or not, again, whether or not we get vaginal estrogen, and that helps that. And we show that studies help that because we don't have those studies on that. That could be a part of that. Okay. But urination at night can be a carryover of what's happening during the day. And I can't tell you
Mm.
how many people walk in and they're like, oh, I just drink a lot of water. And I mean, how many times have you been with your lady friends, your girlfriends, and you're sitting at the dinner table and someone gets up to go to the bathroom right before dinner and then they go again and then they go again and you're like, you pee, like, oh, I have a shy bladder. Or I like, that's just bull. Like a lot of the times our mothers never taught us how to urinate correctly. They told us two things: always go before you leave the house and never sit on public toilet seats. Two of the worst things you can do. Sit on a public toilet seat. You put the paper down if you need to. You got to sit to urinate. You can't hover. No hovering. Number two is these just in cases are going to make you go to the bathroom so much more often.
Huh.
Yeah.
Interesting.
Yeah.
Very interesting.
Yeah. Yeah.
Yeah. I'm just wondering to see if there are any other questions. Is there any parting words? Like, are there, if you had to say, if you had a room full of menopausal women, what, which we did, and we will again, what, if, so you have a room full of menopausal women, what are the three most important things that you would want them to know about their pelvic health?
Well, it's actually really the same. I'm gonna tell you. I was thinking about this because I knew you would ask this question. It's the same stuff we're seeing everywhere, right? So it's like talk to your doctor about hormone replacement. If you're under the age of 60, like you're
10 years
beyond, like
out
you're
of
10
menopause.
years
Yeah,
out,
yeah,
that type
yeah,
of
yeah,
stuff.
yeah.
But let's say either way, vaginal estrogen, vaginal estrogen, vaginal
Do you
estrogen.
think that like people should just be women should
Yes,
just be on vaginal estrogen like
abs-
prophylactically? Yeah.
absolutely. Because you know it's going to happen. There's not a woman out there in her 70s that said, I have the vaginal vault of a 30-year-old just on my own.
That's
Right?
true.
Right?
Yeah.
Lift heavy, but
Yeah.
do it correctly. Okay.
For pelvic health. Okay.
Yes. Because when you
To clarify.
lift,
Yeah.
what are you using?
Yeah.
As long as, but with three conditions, right? Like, so this is, I'm talking preventable. Like, if you have a dysfunction, you have to see someone to get that balanced before you do this.
Yes.
Because you're just gonna perpetuate the situation. But to keep yourself healthy, that is going to be a big thing. And jump. You've got to be able to jump
Mm,
without peeing yourself, right? So, but again, if you have dysfunction, get that checked out first and then work on that,
right.
right? So it's the same stuff. And then the third thing has a lot to do with diet too. So, like, drinking things that irritate the bladder and are going to make it hard for you, like that person was asking about at night, right? So, if you drink Diet Coke, you may as well drink gasoline. It's just as good for you. It, I can't explain it any better because like artificial sweetener and the Coke syrup and all of that bad for your bladder. So like water, hydrate, hydrate, hydrate. We want you drinking your water. We want you drinking. Don't overhydrate, but we want to keep that bladder in good shape and hydrate.
So
Oh wait, we got another
another one. Do you
question.
think I still need therapy if I'm getting up at night already on HRT and vaginal estrogen? How many times? I mean, I guess it's how many times, right? Like, how are you getting up a
So,
lot? And
yeah,
like, is that what you would
exactly.
ask?
Like yeah, or you know, you could absolutely like, is it one time a night but everything else is good? Did you answer any other yeses to these questions or is it just, getting up at night, right? Stop drinking before, after 7 o'clock. Like, don't powerhouse this before you go to bed. But it might help. It might help. There must be there must be other things.
Yeah, I
But
mean, if you have
again,
no
only getting
symptoms.
up once a night and you have no other issues, you're feeling great, you're doing great. That might be habit, that might not be. It's worth a physical therapy, visit to see if there's anything there that might be doing it. Um, at night, it's stopping drinking before 7 o'clock. And if you're heavy exercising before you go to bed, maybe doing some meditation before you go to bed to relax that pelvic floor. Could be, or it could be that you're producing urine at night, and this might be something that might be you, but it's worth a trip.
Awesome. Awesome. You've been amazing as always, full of knowledge.
I don't know where I got the energy today
You
from. I'm not
managed
going to lie.
to pull it out.
I managed, I was
It's good. We
literally
can,
falling asleep.
I know, it's over now. You did great. We both stayed awake. Thank you, everybody who joined us. It was great to have you all here. Thank you so much, Stacey.
Of
Um, we'll
course.
see you soon. Bye, everybody.
Bye.
Thank you.
Thank
Thanks.
you.
Bye.